welcome to The Code Tray, the podcast of the ACCP Emergency Medicine PRN. I'm your host, Christian Kroll, an emergency medicine and ICU pharmacist at the University of Iowa Hospital and Clinics. To view this recorded presentation, head to our YouTube channel at youtube.com/@ACCP-EMED-PRN. And for PRN members, slides can be found under the Libraries and Trees section of the ACCP Communities website.
Now we have Dakota Sicignano, who is a new PGY1 resident at Yale New Haven Hospital. Today, he will be presenting a journal club on use and outcomes of Sugammadex for neurological examination after neuromuscular blockade in the emergency department. Thank you.
I'd like to start off with some abbreviations that you'll see for your reference throughout the entire presentation. The one I really want to highlight is NMBA, which is neuromuscular blocking agent, and that's going to be a big focus here today. To start off with some background, neuromuscular blockade is commonly used as a part of rapid sequence intubation in the emergency department and pre-hospital setting. Rocuronium and vecuronium are two non-depolarizing neuromuscular blocking agents that are administered in the ED. And the use of these agents can lead to prolonged paralysis, delay in neurological examination, or even surgical decision-making. Sugammadex is a modified cyclodextrin that is indicated for the reversal of neuromuscular blockade induced by rocuronium and vecuronium in patients undergoing surgery. Alternative options for the reversal of these neuromuscular blocking agents include acetylcholinesterase inhibitors such as neostigmine. However, Sugammadex is associated with faster time to reversal and lower rates of cholinergic side effects compared to neostigmine, but it does have a longer duration of action. It also should be noted that Sugammadex comes at a high price point, and I'll discuss that a little later in the presentation. The Glasgow Coma Scale is a scale that shows how well your nervous system is working. It is very commonly used in both the operative setting and the emergency department. Measures eye response, motor response, verbal response, and sometimes pupil response. And on the right here, I have how it is scored. In the patient population that we'll be looking at today, they're mainly intubated patients, so their verbal response was not assessed. So they used a modified Glasgow Coma Scale that looked at eye opening and motor response. Eye opening was scored on a scale from 1 to 4, 1 being no eye opening response to 4 being spontaneous. And then motor response from 1 with no motor response to 6 being able to obey commands. Additionally, I just wanted to give some background on the train of 4 monitoring. This is used to evaluate the effects of neuromuscular blockade. Typically, 4 electrical stimuli are applied to a peripheral nerve and muscle twitches are observed. If they say that the first twitch, you have loss of the first twitch, that means you're 100% blocked. And if you have loss of the fourth twitch, that means 75 to 80% of the receptors are blocked. And this is a very common way to kind of assess how well the neuromuscular blocking agent is working and the duration of its action. There are 2 guidelines that mention neuromuscular blocking agents. The first is the Society of Critical Care Medicine Clinical Practice Guidelines, and they recommend using a neuromuscular blocking agent when a sedative hypnotic induction agent is used for intubation. And the 2023 American Society of Anesthesiologists Practice Guidelines recommend Sugammadex over neostigmine as a first-line agent for the reversal of rocuronium in the operating room. But they do mention that despite this recommendation, little is known about the use of Sugammadex in the emergency department. So it should be noted that there are currently no guideline recommendations on the reversal of non-depolarizing neuromuscular blocking agents in the emergency department specifically. Look at some of the previous literature. The first study is Jansen et al., which was published in 2023. It was a structured review of emergency department encounters. It included 48 patients that received Sugammadex for neuromuscular blocking agent reversal. The most common NMBA used was rocuronium at 93.7%, and the overwhelming majority of patients received Sugammadex for neurological examination. I also have the dosing here. It ranged from 2 to 17 milligrams per kilogram with a median dose of 4 milligrams per kilogram. The authors concluded that the most common indication for Sugammadex use was for neurological examination following neuromuscular blocking agent administration for endotracheal intubation, and 4 milligrams per kilogram was the most commonly used dose. And these will be important. This conclusion will be important later in the presentation. 3 more studies that I want to look at. The first is Hyland et al., which was a retrospective case series and single-arm cohort analysis from 2022. It included 11 brain-injured patients receiving Sugammadex. 8 of them had traumatic brain injuries. 3 had spontaneous intracranial hemorrhages. Their intervention was Sugammadex to facilitate neurological assessment, and their endpoints were the impact of Sugammadex administration on neurosurgeon decision-making. And they concluded that all administrations were deemed beneficial to decision-making. Slaxon et al. Was published in 2024. This was a case series that included 11 patients receiving Sugammadex. Similarly, 9 patients had traumatic injuries, 2 patients had spontaneous intracranial hemorrhages. And they also looked at Sugammadex to facilitate neurological assessment. Their endpoint was a little different. It was a change in Glasgow Coma score or return of reflexes, and this occurred in 72.7% of patients. The final study is Hilly et al. That was a single center retrospective cohort study. 24 patients were included. 13 patients presented with intraperitoneal hemorrhage out of the 24, and 15 out of the 24 had traumatic injuries. They looked at low dose versus standard dose Sugammadex for rocuronium-induced neuromuscular block, and they used train of 4 monitoring, so a success rate of a post-treatment train of 4 score of 4. And they found that there was no significant difference found between low dose and standard dose, which is important to note because there is literature out there that does recommend a higher dose of 16 milligrams per kilogram, but this study showed that the lower doses were sufficient. So while these studies show positive conclusions for Sugammadex, it should be noted that they are all very small and retrospective studies, so it's hard to draw strong conclusions or extrapolate the data to larger populations. Now to get into the main article, it was the use and outcomes of Sugammadex for neurological examination after neuromuscular blockade in the emergency department. It was published in 2025, and their objective was they sought to further define the outcomes of Sugammadex use to facilitate neurological examination in the ED. For trial design and enrollment, it was a multi-centered cohort study using retrospective chart review. It was a structured chart abstractation was performed for all emergency department encounters between June 21st, 2016 and February 9th, 2024. This June 21st, 2016 date was the date that Sugammadex was added to the formulary. And they used the electronic health record of Mass General Brigham in the Massachusetts-Boston area. They included patients that received Sugammadex to facilitate neurological examination during their emergency department encounter. And they excluded patients that did not receive Sugammadex during the encounter. Their study variables, their primary exposure was the administration of Sugammadex, and they collected pertinent patient-specific data such as age, sex, race, dosing weight, dose and timing of administration of both the neuromuscular blocking agent and the Sugammadex, neurological examination type, and laboratory values. Their endpoints included neurological injury type, Glasgow Coma scale, procedure type and timing, major adverse events, mortality, and any in-hospital changes to their code status to reflect a more comfort care oriented code status. The Glasgow Coma scale was extracted from nursing and physician notes, just to note. In terms of statistical analysis, they used descriptive statistics throughout the entire study. Now to get into their baseline characteristics, the study had a mean age of about 60 years. It was a 66% male population. The mean weight was 77.3 kilograms. The mean Sugammadex dose was 4 milligrams per kilogram with a standard deviation of 2.8. Within 72 hours of Sugammadex administration, 12 patients passed away, and then within 30 days, 24 passed away. And this patient population had a median Glasgow Coma score pre-Sugammadex of 3 that increased to a post-Sugammadex score of 4. In terms of the types of neurological injuries seen, the most prevalent injury was a multi-compartmental hemorrhage with 15 patients. That was about 31% of the total population. That was followed by intraperitoneal hemorrhage at 11 patients, then subarachnoid was 7, and subdermal hematoma was 6. 3 patients also had ischemic stroke, cervical spine injury, and 3 more had a neurological injury classified as other. It should also be noted that 52% of the patients were resultant of trauma. For dosing, rocuronium was the most common neuromuscular blocking agent to be reversed. It was used in 46 out of 48 patients, so 95% of the total population. Data was available for 35 of these patients, and they received a median dose of 104.7 milligrams, which was a mean of 1.3 milligrams per kilogram. Data from vecuronium was available for 1 patient. So that 1 patient was about 2%, and they received a dose of 10 milligrams. This is 0.13 milligrams per kilogram. 25 of the 35 patients there was data for received 4 milligrams per kilogram of Sugammadex. The mean dose was 346 milligrams, and that ranged from 100 milligrams to 2,000 milligrams. And the mean dose was 4 milligrams per kilogram. In terms of location, this is data from all 48 patients. 2 received the neuromuscular blocking agent in interfacility transport. 13 received it at a referring hospital. 15 received it in the emergency department. And the majority, 18 patients, received it at a pre-hospital setting. It should be noted that the location, if it was not in the emergency department, documentation may be lacking if the patients got neuromuscular blocking agents, for example, in like EMS or at a different hospital. So the timing from when they got the neuromuscular blocking agent to the time they received the Sugammadex may not be completely accurate. And that leads me into timing. So time of administration data was available for 22 patients. The mean time from neuromuscular blocking agent to Sugammadex administration was 109.9 minutes, with a range of 31 to 283 minutes. In terms of their outcome, Glasgow Coma score was obtained before administration in 43 patients, so almost 90%. 42 patients were scored as 3T, one patient was scored as 4T, and just to remind you back to the beginning, the T indicates that verbal response was not assessed. So 2T is no eye or motor response, and 10T would be complete eye and motor response. Glasgow Coma score was obtained after administration in 35 patients with a mean score of 6.4 plus or minus 2.4. And 34 patients had a reliable Glasgow Coma score before and after administration with a mean increase of 3.8. Secondary outcomes, 23 patients underwent an invasive procedure within 24 hours after administration. Another 3 underwent a procedure within 72 hours. 12 patients died within 72 hours of Sugammadex, and another 12, so 24 total, died within 30 days. And code status was changed to comfort measures only for 22 patients during their hospitalizations. Adverse events were overall rare. 4 patients experienced bradycardia, 2 patients experienced hypotension, and no patients experienced cardiac arrest during the trial. Adverse events, it should be noted that adverse events may be missing because the trial is retrospective and the data may actually appear lower than it is in the actual population. The authors concluded that the use of Sugammadex outside of the postoperative setting is overall rare, but was associated with infrequent adverse effects, high rates of procedures within 24 hours, and significant in-hospital mortality. They also concluded that the change in Glasgow Coma scale was observed in most patients despite receiving Sugammadex greater than 1 hour after neuromuscular blocking agent administration, with a maximum observed interval of greater than 4 hours. And prospective data is needed to assess the impact of Sugammadex on decision-making. Now, to get into the strengths of the trial, it was a multi-center design. They used 9 different hospitals in the Mass General Brigham Health System. Their screening criteria was very vast. They screened all emergency department encounters from the time that Sugammadex was added to the formulary. They also used a standardized outcome measurement and Glasgow Coma score, which is a widely used measurement for these patients with neurological injuries. And it was also a real-world emergency department setting. These were actual patients that were coming in, and they were all screened. In terms of limitation, it was retrospective in nature. This means that data could be missing due to the fast-paced nature of the emergency department, and there could be a lack of documentation. The manual chart review was only completed by one author, so while this is very subjective, it could also be a strength because it's standardized throughout the process. There was lack of a comparator group. Sugammadex was not compared to anything else. There was a small sample size, which makes it hard to draw correlation or make conclusions and extrapolate this to a larger population. It was completed in an urban setting in the Boston area, which the hospitals are much closer together and the larger health system might have more resources compared to a community hospital or a hospital in a more rural setting. The GCS use is subjective and can vary due to multiple factors. For example, if one person did the evaluation before Sugammadex, they may interpret motor response or eye response differently than the person that did after, and this could lead to a different score. They also did not give any information on train of 4 monitoring, so that data could not be presented. And finally, there was lack of a patient with status epilepticus as the underlying injury. So status epilepticus accounts for 1% of all emergency department visits. And in this patient population, the paralytic may stop their convulsions. However, their seizure activity will still continue in their brain and CNS. So it's important to reverse the neuromuscular blocking agent to determine the patient's disposition in terms of their seizure. Now that I've gone through all the data in the trial, I'd like to have a little discussion about the use of Sugammadex in the emergency department. First, talk about cost. The study did not evaluate cost directly, but Sugammadex does have a very high price point. For comparison to neostigmine, a 4 milligram per kilogram dose of Sugammadex is about $277, whereas neostigmine would be closer to about $10. So a pretty big discrepancy there. In terms of timing, this was a retrospective review like I just mentioned, so timing may be inaccurate. And the average time to Sugammadex administration was about 110 minutes. So it could be theorized that the paralytic may have worn off by then, but train of 4 monitoring was not used to actually determine that. There is other literature that is starting to accumulate in neurological patients that have train of 4 monitoring done over an hour after receiving neuromuscular blocking agent and still being paralyzed. However, without the train of 4 monitoring and Sugammadex in this trial, it's hard to determine the optimal point. In terms of dosing, there is no dosing guidance in the ED as literature is mainly focused on the perioperative setting. So dosing information was provided, but it's very hard to extrapolate to larger populations. And like I mentioned before, our adverse events, there was a low rate in this trial, but due to its retrospective nature, it's hard to determine the true rates or if there is missing data. In literature, there's an incidence of hypersensitivity with Sugammadex up to 9.5%, with bradycardia, hypotension, QT prolongation, and cardiac arrest also being reported. And also, the risk of coagulopathy, especially in patients with brain bleeds, is higher, so it should be something to make note of. And finally, for intervention, patients with neurological injuries need evaluation as soon as possible, but no patients in this trial had a change in their final outcome or their disposition due to the administration of Sugammadex. So it could be theorized that they could have waited a bit longer for the paralytic to wear off and then taken the next steps. In terms of my personal conclusions, this study is part of limited literature that evaluates the use of Sugammadex to reverse neuromuscular blocking agents in the emergency department. The use of Sugammadex in the emergency department to facilitate neurological examination after neuromuscular blocking agent administration should be based on a risk and benefit in a case-by-case scenario. Further research is needed to determine the optimal Sugammadex dosing and the incidence of adverse events in a larger population. And further research is also needed to determine the proper instances to emergently reverse neuromuscular block in the emergency department patients. Here are my references. Thank you.
If you have enjoyed this presentation content and would like to hear more, subscribe via your favorite podcasting app. Additionally, make sure to check out our YouTube page for all recorded presentations. Thank you for listening to this week's ACCP Emergency Medicine Journal Club presentation. Join us weekly for review and discussion of new journal articles in emergency medicine. This podcast provides general information only and does not offer individualized medical or professional healthcare services, including pharmaceutical advice. The contents and materials in the podcast are not intended to be a substitute for inpatient pharmaceutical advice, diagnosis, or treatment. And the use of the contents and materials in the podcast does not constitute a pharmacist-patient relationship. As a result, the information in and materials linked to this podcast are applied at the user or patient's own risk. Users or patients should consult their physician or personal healthcare professional. The user or patient should not ignore or delay seeking care because of something they heard on this podcast. In case of an emergency, the user or patient should contact their physician, call 911, or go to the nearest medical emergency facility. The views and statements expressed on this podcast are those of the host and guest and should not be interpreted to reflect the official position or policy of ACCP or the Emergency Medicine PRN.